In the event of loss of cabin pressure, the overhead oxygen masks will be deployed automatically. Continue breathing through those masks. If you are a frequent flyer or you travel by air, you must have heard this announcement routinely. What's with those masks? Why do such situations arise where extra oxygen is to be supplied? The answer is simple. If there is lack of oxygen, if there is a possibility of decreased oxygenation of blood, then extra oxygen needs to be provided. Simple. Now look, the air travel will be 1 hour, 2 hours or even more, 3 hours, 4 hours, and it is at a height of 30,000 feet. At that high altitude, there's going to be low barometric pressure, therefore low oxygen tension in that air, and that means low oxygenation of your blood. So oxygen needs to be provided once the air travel starts. I mean, once you are in the flight. Now, for 2 hours and 3 hours, people can't sit with those with those oxygen masks. That means there is the other mechanism to provide extra oxygen. What is it? That they pressurize the cabin. For the entire flight duration, the cabin is pressurized. So that's the other way. Increase the pressure of the air that is being delivered, increase the pressure with which oxygen is delivered. More oxygen will reach your blood, oxygenation will be maintained. So at the very basic, remember this, either you can give extra oxygen by mask, that is 100% oxygen, or maybe 40, 60, 80%, or you can give oxygen under high pressure. That also improves oxygenation, because from alveolus to the blood, oxygen delivery is much faster and greater amount of oxygen in the blood. So that's very interesting fact. So I thought I will just start the video with that. For example, commercial aircrafts usually cruise at 30,000 feet, and at that height, a cabin needs to be pressurized. As I said, they can't give oxygen masks for the entire journey. I mean, that's not feasible. So instead, cabin is pressurized, so air and oxygen is delivered under pressure, and that will maintain the oxygenation. And cabin pressurized to an equivalent of around 6,000 feet. That's generally the norm. The pressure at 6,000 feet, that whatever pressure is at 6,000 feet, that much equivalent pressure is inside the cabins at even at 30,000 feet. At the altitude of 30,000 feet, the PO2, and I'm saying not in the aircraft, at that altitude, PO2 is 120 mm of Hg in the inspired air, and alveolar PO2 in healthy people would be around 53 to 64 mm of Hg, and that's half of what we breathe at the sea level. At the sea level, the alveolar PO2 is in the range of 100 to 104 mm of Hg. All right, and therefore oxygen saturation also is reduced to some extent. But healthy people will tolerate it well, and with this pressurized cabin, then there would not be any problem at all with the oxygenation of blood. All right, so an interesting fact. Now let's start with the real topic of the video, and that's oxygen therapy mainly, and the oxygen toxicity. Well, I'm not for a moment suggesting that oxygen masks result in oxygen toxicity. No. What I mean is, if the oxygen is delivered continuously through the mask for more than 8 hours, then it might lead to some kind of toxicity. All right. Let's have a look at this topic now in detail. Well, universities, in the event of universities asking this question in the form of short note, etc., you have to write it under 3 headings: indications and usefulness of giving the oxygen, procedure, how actually you give oxygen, and finally the toxicity. All right, let's start with the first part, and that's indications. Where is this extra oxygen useful? Already we have said that oxygen can be given either by face mask as 100% oxygen, or it could be a hyperbaric oxygen. Oxygen under high pressure is delivered. Hyperbaric, bar is pressure. Okay. So let's see one by one. 100% oxygen by mask. It will be useful in the hypoxic situations. Obviously, there is lack of oxygen. You are providing extra oxygen. Hypoxic situations of any etiology, I mean like or some important etiologies like high altitude sickness. You must have heard that these film actors, when they are shooting at high altitudes like in the Ladakh or something, they carry oxygen cylinders because low barometric pressure at high altitudes, that means low PO2 in the air, that means low oxygenation of the blood. Then COPDs, of course, bronchial asthma, status asthmaticus. In all such conditions, you will need to provide 100% oxygen. What is 100% oxygen? What does it mean, giving 100% oxygen by mask? At the sea level, when we inspire air, it only contains 20% oxygen. Means this air, it's only 1/5 fraction is available in the form of oxygen. Only 20%. When you give oxygen by face mask, it could be 40% or 60%. That means technically you are increasing the oxygen amount, oxygenation, by 2-fold or 3-fold. Or it could be even 100%, which will mean 5-fold increase in the oxygen that will be delivered compared to the normal air, normal inspired air. So that's the meaning of oxygen delivery by face mask, and 40, 60 or 100%. The second one is hyperbaric oxygen. Means oxygen delivered under high pressure. Many hospital settings do not advocate this hyperbaric oxygen therapy, but nevertheless it is useful in certain conditions. For example, carbon monoxide poisoning. Now first some basics. How is this useful, hyperbaric oxygen? If you give oxygen under high pressure, that means the alveolar PO2 will increase, right? Because you are giving it under high pressure. So PO2 is higher in the alveolar air, and then that means it will diffuse into the blood, and the PO2 in the blood will also rise. Arterial PO2 will be much higher compared to the normal blood. So that's the basis of giving hyperbaric oxygen. We give it in carbon monoxide poisoning, and we will see that why it is given. Then gas gangrene. You know, the microbe of that causes gas gangrene is it thrives in anaerobic conditions. So when you give hyperbaric oxygen with high PO2 in the blood and in the tissues, it won't survive. Then even for treating decompression sickness, all right, to treat the decompression sickness, which is a nitrogen induced problem, or radiation induced tissue injury, or any such injuries or ulcers which take time to heal, they are slow to heal, like diabetic leg ulcers or other wounds which are slow to heal, hyperbaric oxygenation is said to be useful. Yes, one more, rescue of skin flaps and grafts. You know, here what happens is that a skin flap is grafted, let's say by the plastic surgery or plastic reconstruction or something like that. What happens is that the circulation to these grafts or flaps, skin flap, which is suppose mounted, placed on some burnt area or something, the circulation is marginal for these grafts or flaps, and because of that there is a possibility that the graft might fail, it might get rejected, or it may not survive. And therefore, if you give hyperbaric oxygen, then the vascularization also improves, and the graft or the flap will survive. So these are the conditions in which carbon monoxide, I beg your pardon, in hyperbaric oxygen therapy can be given, can be advocated. All right. We saw where the oxygen is useful. We will also see where the oxygen is not useful, useless. Oxygen-rich gas mixtures are of hardly any use in hypoperfusion. Simple, because if there is less perfusion to the tissues, you are giving more oxygen, but it won't reach the tissues. Or anemic hypoxia. Yes, if there is severe anemia and there is hemoglobin already very low, then it may not be that useful because there is low RBC count, low hemoglobin to carry that extra oxygen. Or histotoxic hypoxia, obviously, I mean the tissues are not able to utilize the extra oxygen that you are giving. All right. Second part is aim of the oxygen therapy. We saw so far what are the indications. When do you give oxygen? The second point is, what will be the aim, goal of your oxygen therapy? Suppose you have started 100% oxygen or hyperbaric oxygen. What will be the goal that you want to achieve? How will you track whether it is being useful or not? Let's see. Maintain saturation near 93% or maybe more than 90%. Look, in the COPDs and severe conditions, the O2 saturation of hemoglobin decreases maybe up to 70% or even less. And therefore, I mean, it's very threatening, life-threatening. So, you will see the saturation. It should be brought above 90%, should be maintained above 90%. That's the aim of giving 100% oxygen by mask. What is the aim of hyperbaric oxygen therapy? Now, this is little conceptual, so I want you to focus on this part and understand clearly. We are talking about carbon monoxide poisoning. Let's take the case of carbon monoxide poisoning, and we are going to start hyperbaric oxygen therapy. Okay. Many students wrongly believe that if you give oxygen under high pressure, it is likely to displace carbon monoxide from hemoglobin. You know what is the problem with carbon monoxide poisoning? It goes on to bind with hemoglobin. Most of the binding sites on hemoglobin will be occupied by carbon monoxide. So, your hemoglobin is not available to carry oxygen. That's the problem. Hyperbaric oxygen is given not to displace that carbon monoxide from hemoglobin, which is wrongly believed by many students. Then it is given for what? Take the point. Oxygen is transported in the blood in two forms. 97% with hemoglobin and 3% in the dissolved state in the plasma. This is free oxygen dissolved in the plasma water and carried. So hemoglobin and plasma carry the oxygen. Now major form is hemoglobin. In the carbon monoxide poisoning, hemoglobin won't be available. Carbon monoxide has bound to most of the hemoglobin, but the other form is available. The free form in the plasma, that is available. So, you are giving hyperbaric oxygen to increase the free oxygen content in the plasma. How is that achieved? Look, first of all, free oxygen dissolved in the plasma is calculated like this: PO2 into solubility coefficient. I repeat once again. Free oxygen dissolved in the plasma water is equal to PO2 in the plasma into solubility coefficient for oxygen. Solubility coefficient for oxygen is a fixed value. We know it. 0.003 ml is of oxygen is dissolved in every 100 ml of plasma per mm of Hg of PO2. So if the PO2 is 2 mm of Hg, then in 100 ml plasma 0.006 ml will be dissolved. If the PO2 is 3 mm of Hg, then 100 ml plasma 0.009 ml will be dissolved. That's the meaning of this. So you increase the PO2, the dissolved O2 content will go on increasing. All right? That's the basis of giving hyperbaric oxygen in carbon monoxide poisoning. That you deliver oxygen under high pressure, then in the plasma, the PO2 will be increased and increased and increased. And high PO2 means more and more oxygen will be dissolved in the plasma. The aim is to increase the dissolved oxygen in the plasma because hemoglobin is unable to carry any oxygen for now in the poisoning case. Okay, but then how much? How much should it be? Now, by heart this. 6 ml in 100 ml blood is the minimum oxygen required for survival of the tissues. How much? 6 ml in every 100 ml of arterial blood. Right now I'm talking about whole blood. For the tissue's survival, how much oxygen should reach them? 6 ml oxygen, 6 ml of oxygen in every 100 ml of arterial blood should reach the tissues. Now I am saying whole blood. That means with the hemoglobin or in the plasma. It could be all 6 ml carried by hemoglobin, or all 6 ml carried by the plasma, or 3 ml by this and 3 ml by this, whatever way, but 6 ml of oxygen should be transported to the tissues, minimum 6 ml for the survival of the tissues. Now in carbon monoxide poisoning, hemoglobin is not available, carbon monoxide is sitting there. That means you are left with plasma oxygen, oxygen dissolved in the plasma. So all that entire 6 ml, which is minimum required, will have to be carried in the plasma in the free form, isn't it? That means from the normal 0.3 to 0.4 ml, normally our plasma contains about 0.3 to 0.4 ml oxygen in every 100 ml plasma. From that level, we will have to bring it to the 6 ml in every 100 ml plasma. What is the method for doing that? Increase the PO2. And that's the basis of giving hyperbaric oxygen in carbon monoxide poisoning. Deliver oxygen under high pressure, that will increase the PO2 in the plasma. And how much actually? Look, normally about 0.3 to 0.4 ml is dissolved in the plasma. That is when PO2 is 100 mm of Hg. Now we want 6 ml to be dissolved in the plasma, in 100 ml plasma. Then the PO2 in the plasma will have to be 2000 mm of Hg. Yes, from 100 we will have to raise it to 2000 mm of Hg. And how do you achieve that? By giving 100% oxygen at 3 atmospheric pressure for a certain time period, let's say half an hour or slightly more. That much will be sufficient for the oxygenation to be achieved. So that's the aim of giving hyperbaric oxygen in these conditions. Particularly in carbon monoxide poisoning case, you are giving it mainly to increase the dissolved oxygen content in the plasma. Eventually, carbon monoxide will be dissociated. It has got a certain half-life and it will be dissociated and will be expelled out. But till then, we have to achieve this. All right. So indications and aim of the treatment when you start it, and now we'll see how, means the procedure. Initially given by face mask or nasal cannula, and 40% to 60% by the mask. So from 20% which we normally inspire, it will be 2-fold or 3-fold increase in the inspired air. Inspired O2 concentration can be adjusted according to the results of the pulse oximetry. Very important point. As we are saying, what is the aim and how do you track that whether it is happening or not? Pulse oximetry and arterial blood gas analysis, that has to be observed, and that will tell you about the saturation, that will tell you about the PO2, etc. So track it whether you are achieving that aim or not, and keep a watch on hypercapnia as well. If the person is having hypoxia and it's because of the depressed breathing, there may be accumulation of carbon monoxide as well. There may be hypercapnic situation. So keep a watch on that. Another important aspect, clinically speaking, some patients of severe chronic COPD and type 2 respiratory failure, they develop abnormal tolerance to the raised PaCO2. Let's explain this further. We have oxygen, we have carbon dioxide. Okay. Now, oxygen stimulates the peripheral chemoreceptors and thereby stimulates breathing. I mean, in hypoxic situations, it's the stimulation of the peripheral chemoreceptors that stimulates breathing. And there is a central chemoreceptor in the medulla. Carbon dioxide stimulates the central chemoreceptor in the medulla and thereby stimulates the breathing. All right? Consider these conditions, clinical conditions. They already have a raised PaCO2, and such a consistently persistent high CO2 in their plasma, in their blood, means their central chemoreceptor develops some kind of a tolerance to that raised CO2 level. Normally, increased CO2 will enter the brain, enter the CSF, and will stimulate the central chemoreceptor and thereby stimulate the breathing, ventilation. But these patients, they have developed some kind of a tolerance to that CO2, raised CO2. They have a raised CO2, but they have developed tolerance to it. Their chemosensitivity to the CO2 has been lost. So what happens is, even if they have raised carbon dioxide in their body, their ventilation is not getting stimulated via central chemoreceptor. All right. So that's the case with particularly these conditions. What happens is excessively high PCO2 and the respiratory center in fact getting depressed instead of getting stimulated. It has developed tolerance to that high carbon dioxide because they were high for long durations. So they may become dependent on the hypoxic drive to breathe. This is looking paradoxical. You want to remove hypoxia, for which you have to give oxygen. That's a settled issue. But in some patients, you want them to be little hypoxic. Why? Because their other stimulator of ventilation, that is carbon dioxide, is not working. So carbon dioxide stimulation of ventilation via central chemoreceptors is not working. What is the other stimulus left? Hypoxia via peripheral chemoreceptor. And therefore, you would want them to be little hypoxic in the sense that they are dependent on that hypoxic stimulation of peripheral chemoreceptors and driving the ventilation via that. Okay, so only in these patients, you will have to lower the concentration of O2. Don't correct that hypoxia immediately and aggressively. Let it be little hypoxic. So lower the concentrations of O2 up to, let's say, 24 to 48% by Venturi mask. And there is also another mixture called as a carbogen. 95% O2 and 5% CO2 is added in the mixture. For what? For that same purpose, stimulation of the central chemoreceptors by the CO2. I am saying now in other patients. Okay, the first part was in the certain patients like chronic severe COPD or type 2 respiratory failure. That is where you lower the O2 concentration in the mask and keep it just 24 to 48% because you want the hypoxic drive of the ventilation to continue. Okay. In other patients, if you are giving oxygen, instead of giving 100% oxygen and correcting the hypoxia immediately, add 5% carbon dioxide to 95% oxygen. This will stimulate the central chemoreceptors also in other patients who have not developed tolerance to the carbon dioxide. Okay. All right. Now let's see what happens when we give oxygen. 100% oxygen at 1 atmospheric pressure may be tolerated for up to 8 hours. No problem if it is given continuously without any symptoms. 100% oxygen for more than 8 hours will cause some problems. Yes, there will be substernal distress in the respiratory cage, nasal congestion, sore throat. So there will be localized problems confined to the respiratory apparatus. 100% oxygen at 2 to 3 atmospheres. Now hyperbaric may be tolerated without any symptoms for up to 5 hours. So 100% oxygen at 1 atmospheric pressure, good enough up to 8 hours, good, no problems. If 100% go to 2 to 3 atmospheric pressure, then up to 5 hours it can be tolerated. And now let us talk about the oxygen toxicity. Having discussed about the indications, aim, the procedure, now we'll see the toxicity. Oxygen is necessary for survival, that's good, that's great, but excess of it is going to be toxic. So oxygen toxicity is due to the formation of reactive oxygen species. Superoxide anion, H2O2. Let's see what happens in the oxygen toxicity. Prolonged exposure to the high PO2, bronchiolar and alveolar membrane inflammation. So just divide it into two. One, the local effects means respiratory side effects and non-respiratory side effects. Respiratory side effects of giving oxygen will be these. There can be pulmonary edema, atelectasis, fibrin formation and lung consolidation. So these effects, how do they occur? Why do they occur? They occur from inactivation of many structural repair enzymes. Those free radicals or reactive oxygen species, they cause inactivation of many structure repair enzymes, and therefore in time these structures like alveolar membrane etc. Can't be repaired properly and cause damage, and of course oxidation of certain cellular constituents as well. So that's the cause for the side effects or toxicity. And the effects on non-pulmonary tissues, mainly the CNS. Okay, so remember this, the side effects, toxicity of oxygen locally or on the respiratory apparatus and outside it in the CNS. So free radicals, now remember this part, free radicals, they oxidize the PUFA component of the cell membranes as well as enzymes involved in the energy homeostasis. So oxidation of these PUFA components, even cell membranes have the fatty acid component, and therefore free radicals are going to cause damage. At 4 atmospheres, symptoms of toxicity may develop in 30 minutes. So you have to be cautious. Don't be overzealous, don't be over aggressive in the treatment and give it at high pressures. And at 6 atmospheric pressure, which is too high, convulsions develop in a few minutes. So be mindful, watchful of all these side effects. What are the manifestations? If you give hyperbaric oxygen, muscle twitching happens, tinnitus, ringing in the ear, dizziness, convulsions, coma. Particularly if you are giving above 4 atmospheric pressure, then it results in these manifestations. Infants, newborn babies sometimes are developed with respiratory distress syndrome, and therefore oxygen is a must. So if you are giving hyperbaric oxygen in these neonates, there is development of lung cysts and densities, and all this may result in bronchopulmonary dysplasia. So local side effects, local means related to the respiratory apparatus, to the lungs. Also, now this is important again, retrolental fibroplasia. This is the ocular side effect in the neonates who are being given hyperbaric oxygen. They are born and they are having respiratory distress syndrome. You need to treat it urgently. You are giving hyperbaric oxygen. But if it is for prolonged duration, they may develop retrolental fibroplasia ocular side effect behind the lens. What happens is formation of opaque vascular tissue in the ocular media. Please understand this, that if you are giving oxygen to the tissues, there is going to be a vascular growth. Now in this case, the vascular growth will be in the eyes, in the ocular media, and it is not transparent, it is opaque. So there will be visual abnormalities, visual defects will occur as a result of hyperbaric oxygen therapy. It should not be administered at a stretch for more than 5 hours and not more than 3 atmospheric pressure, right? So that's how the side effects develop if you give for 3 atmospheres for more than that specified time. Particularly you have to be watchful of this, because the patient is a neonate, the patient won't be able to explain the symptoms, and therefore you have to be watchful. I'll explain this part, how these opacities develop, or the side effect develops behind the lens, retrolental fibroplasia. So it would be in the vitreous humor behind the lens, or in the retina. In fact, even in the retina, retinal defects also possible. What happens is normally when a child is born, there is development of photoreceptors. Their growth occurs from central part of the retina to the peripheral parts. And let's have a diagrammatic view. Let's say central part to peripheral parts, the photoreceptors, they grow in an orderly fashion. That is how the vision is going to develop from the newborn baby onward. And therefore, as the photoreceptors are developing, there is going to be vascular supply to those developing photoreceptors also. And therefore, normally, under normal conditions, the vascularization of the retina is in a very orderly fashion, that the photoreceptors will grow from central part to the peripheral part, and that is how they will pull their vascular supply also. So blood vessels will also grow in a very, very orderly fashion. But if you give hyperbaric oxygen, then the photoreceptors might develop prematurely in some parts of the retina, not in an orderly fashion. And therefore, the vascular growth also will occur in a very disorderly fashion. This resulting in severe visual defects. So that was about the side effect or toxicity in the neonates, particularly retrolental fibroplasia behind the lens. And the other things like fire and explosions are the hazards with 100% oxygen. You know, there are cylinders and they may catch fire because they contain oxygen, or even explosions. So you have to be careful of all of these things. They should be properly stenciled or properly marked, the oxygen cylinders, whether it's 100% or under high pressure, etc., or high pressure delivery is to be given rather. But all of these things you have to be mindful of. Oxygen is life, it is important for life, but how to give, when to give, and how much to give, all these things should be very well known as a clinician.